Hi, everybody. I'm Dr. Carolyn Alexander, and my dear colleague Robyn O'Leary is here with us today. We're hoping you're all having a wonderful day. I hope your summer's going well. We're here to talk about a great topic, the lab process of embryo creation, and we're happy to answer any questions you guys have. And I was born and raised in LA, and I lived in Baltimore for nearly 8 years. My research has been on polycystic ovary syndrome, as well as recurrent pregnancy loss and oncofertility, or patients with cancer who need to think about fertility preservation. I went to UCLA. I go Bruins, but a lot of my families are Trojans, so we still respect USC. And I went to UCLA Medical School, and then I worked at Johns Hopkins Hospital for residency and fellowship. We all put a lot of heart into our every patient and every day here at SCRC. And so next slide, Robyn will introduce herself too.
Hi, everyone. My name's Robyn, and I'm the IVF laboratory manager. I'm from California, a Northern California girl, though, who kind of migrated down south as I got older. I went to Cal Poly San Luis Obispo for my undergrad, and then skipped across the pond for a master's degree over in England for a little while. I've been doing embryology for a little bit over 15 years and been a part of a lot of different aspects of research in the IVF lab, but we love doing webinars and teaching people about what we do in the IVF lab.
Awesome. That's great. So at Southern California Reproductive Center, we've been here since over 25 years. Our embryology lab has been in the same facility. We work closely with many fertility doctors, but Dr. Suri and Dr. Danzer are our founding doctors here. And I've been here for using the embryology lab since 2007. And we have Dr. Susan Maxwell in Santa Barbara. Our on-site surgery center is here in Beverly Hills, and we have a full center in Santa Barbara as well, and a monitoring center in Pasadena as well. We have experienced embryologists, and thank you, Robyn. It's been such an honor to work with you. We do a double witnessing verification system here, so 2 people check all the information for every patient. Vitrification or flash freezing for egg freezing, as well as blastocyst freezing. We do pre-implantation genetic testing for aneuploidy screening, as well as for single gene disorders or X-linked disorders or autosomal dominant disorders. We look at all the chromosomes, as well as if some couples want family balancing or specific gender selection. EmbryoScope is a time-lapse morphokinetics evaluation of the embryos, and that's decided with your clinician specifically. We have certified directors and collaborations with other CAP accredited laboratories too. Tomorrow is World Embryologist Day and World IVF Day, so it's a big honor. It's been we've been all dedicated and committed to our field. We'll talk today a little bit about age and what that has an impact on egg and sperm quality, how we do a detailed medical history and testing, optimizing our body before IVF, timelines and the process, and the embryo creation in the lab and freezing of embryos, and what to expect for the embryo transfer day. We are happy to answer any questions too. Feel free to put them in the chat, and then we can answer them at the end as well. July 25th, World Embryologist Day. So our lab director, Lisa, will be speaking with Louise Joy Brown, the world's first IVF baby. I love her so much too, and I'm excited to see this tomorrow. And so it'll be a great talk. We'll talk about what is infertility. So in a couple where the woman is under 35 and they've been trying for a year with regular periods, that is considered infertility, because typically we would hope there would be a conception by then. When we're over 35, the ovarian function starts to change quicker in terms of lowering our egg reserve, our egg quality, and things like that. And so it's important to recognize that when you've been trying for 6 months, it may be important to talk to your OBGYN about pre-testing to understand your ovarian reserve tests, as well as discussing the options of evaluating the fallopian tubes and a detailed semen analysis. What I think is fascinating is that when we're in our 20s, unprotected intercourse, the chance to conceive is in the 20s, 25%. And so it starts to go down as time goes by. Our average age of patients here is in the late 39 to above 40. And so most of our patients tend to be on the older side, but it is important to recognize that there's this momentum to understand our hormones and fertility, and people are checking and discussing it more than in the past too. So age and female fertility. So as time goes on, our chance of conception per month starts to change. I tend to be very optimistic. So every month has a chance to have the golden egg and an opportunity to get a healthy pregnancy, but it is important to understand to get a checkup. And as you can imagine, the genetics of those eggs that have been in our body since we were a baby, they start to change. The mitotic spindle starts to get a little more sticky. And so when fertilization happens, an extra chromosome could get carried during that process, and that can cause a trisomy or an abnormal pregnancy. And so the genetics of our eggs also start to change, especially when we turn 35 years old. So when we were born, we had 7 million eggs in the ovaries. And as time goes by the time we hit puberty, we start to have around 400,000. And during our fertile window, we have about 400 to 500. People, every time we ovulate, 1 egg, usually per month, naturally. But in general, we may have follicles that could have many, each follicle can have an egg, and you may have a chance to get more eggs with the IVF process because you can take follicle stimulating hormone, which excites those follicles, so that instead of ovulating the 1 egg for the month, we're hoping to get a pool of eggs. We do take a detailed medical history. We want to make sure you're up to date with your pap smear and annual physical exam with your primary care doctor. We'd like to make sure you're as fit as possible, exercising, eating a healthy diet, thinking about all the vitamins that are helpful, especially folic acid, which can prevent spina bifida. We talk about the male. Some men are on blood pressure medications or Propecia or finasteride and Rogaine, and those can have ramifications for sperm quality too. We do a lot of testing here, including the HSG or fallopian tube test, as well as the semen analysis or sperm DNA fragmentation testing. So we're asked every day, what is AMH? AMH is called anti-Müllerian hormone level. It's produced by the granulosa cells, or the cells around the egg, and those cells produce a hormone that give us a reflection of egg supply. It was never intended to be used as a test to predict who would conceive. And so sometimes patients do some of the home tests or get an alarming level with their OB, and then they go and try unprotected intercourse and they get pregnant right away. And so it was never used as a tool to predict who's going to conceive. It's used as a tool to tune into your ovarian reserve. And so we have certain targets we're hoping for. When you're age 26 to 29, we want the AMH 1.96 to 5.88. When you're 30 to 35, we want 1.4 to 4.2, 36 to 39, 0.84 to 2.8, but above 1 is ideal. And then 40 to 44, it tends to go downward, but at 0.42 to 1.4 is normal. Over 44, there are still chances. It's just the AMH, which is the reflection of egg supply, is 0.14 to 0.42. So it starts to trend downward. On the ultrasound image here, you see each little black circle there has one microscopic egg that's smaller than a grain of salt. And sometimes if we are heavy tobacco users or vaping or CBD oil, sometimes we notice that the follicle count could be impacted by toxins. And so it's important to recognize that lifestyle modifications may be encouraged. Every person is unique, and so there's no clear thing. You talk it over with your doctor and think it through for your personal situation too. Next slide. We encourage vitamins, prenatal vitamins, because it improves pregnancy outcomes. CoQ10 is a supplement that improves mitochondrial function. And so your doctor may discuss this with you. And we do like vitamin D because in the male factor or female, we like that the vitamin D levels 30 to 50. And so it's good to check your vitamin D levels and keep them at a good target too. Next slide. So what's involved with the semen analysis? So we like men to abstain 2 to 5 days before their appointment. We like the volume above 2 milliliters, the concentration over 20 million per milliliter, the motility, which is how fast they're swimming, 50% and above, and the morphology to be 14% and above. And it's important to understand that we do catch male factor or male infertility as the cause of couples struggling for about a third or 40% of the couples. And so it tends to be important to get tested because it does take some time to improve sperm quality. And we work closely with urology if there's any varicoceles or any problems or any hormone imbalances. And sometimes in some men will catch a thyroid dysfunction or prolactin. And so we work closely together with the urology team. The image on the right is the sperm. And I think it's always fascinating to think plastic pollution, microwaving things in plastic, also thinking about artificial sweeteners, as well as some like extreme binge drinking and things like that may not have a good impact on sperm quality too. Next slide. Men can think about taking CoQ10 and vitamin D. And then there is a vitamin that's specific if the semen analysis has anything abnormal that we talk about called Proxeed Plus. Not everybody has to take this because sometimes it's too much of a good thing, but it does have some benefits for male factor infertility too. Next slide. We do really have a holistic approach here. We have Jen Schulman, an acupuncturist downstairs. We work closely with many different acupuncturists. We work very closely with nutritionists. Like I talked to a patient today and she really always skips breakfast and really does intermittent fasting for 16 hours. And some people that makes the hypothalamus and pituitary not want to ovulate as regularly. And some people it works fine, but it's just good to think about it because there might be something that may benefit you. Meditation, mindfulness, journaling. I've had a few patients, even for myself, when I was trying, I felt like it helped me break the fear factor of what if something happens or what if something is problematic. And so it kind of helps you recognize that we'll do everything work together. And our teams here are wonderful and very dedicated to making sure you feel cared for. Next slide. In terms of nutrition, we do recommend lots of fruits and vegetables, colorful fruits and vegetables, really avoiding fried food, avoiding too many white carbohydrates and starchy things, amping up protein in your diet. If you're vegan, sometimes we may have to have a discussion about some options to improve some of the amino acids that may be missing. And then pescatarian, it's harder because sometimes too much fish can have mercury. So we always want to balance out what we're doing in terms of, and it's a specific discussion with your doctor. Next slide. It's important to avoid too much alcohol, cannabis if we can, and avoiding tobacco. With men, it does take about 2 to 3 months to improve sperm if we're smoking. And some men need Chantix to talk it over with their primary care doctor. And I've encouraged that many times over the years. And people told me, thank you so much, that saved me. I didn't realize it was going to work that well for me. So sometimes it's good to kind of talk it out if you need that. And next slide. The egg retrieval, so we prepare you for a month or two with lifestyle, get the genetics screening done, make sure your pap smear, if needed, a mammogram's up to date, prepare your body. And with IVF, it's a two-step process. The first is ovarian stimulation, which takes 10 to 12 days of injections called follicle stimulating hormone. There are about 5 or 6 important visits to recognize how the follicles are growing and your estradiol level. We open at 6:30 in the morning, so if you need to hurry in and out, we can get you through to get to work, because I know some of us have responsibilities, and so that we accommodate that. And then the retrieval day, you can't go to work that day, and we could predict it by 90% the retrieval day. That day you have light anesthesia or anesthesia to feel comfortable during the procedure. And then for that week afterwards, you're pretty bloated and sore, some breast tenderness. Occasionally people have constipation. So it's good to get ahead of it with fiber or magnesium if needed. And during that part of it, Robyn will go over how the embryos are growing and how the process after that too. Next slide. The egg retrieval is a thin needle through the vagina under propofol sedation. And so we carefully get each egg out. And I always say the furthest away one, the hardest one to get will be the baby. No, but it's just, we try everything in our power to get every single potential egg that we can possibly get. Next slide. Robyn, your turn.
All right. This first slide here just kind of is a zoomed out description of what kind of goes on in the IVF lab. And for us, we count day 0 as the retrieval day. And also if you're doing an IVF cycle, the sperm preparation day. And that's also the same day that we do insemination, whether that's ICSI or natural insemination. And if you're doing an egg freeze case, the eggs are frozen on the same day as well. And then we move on to day 1, which is when we check everything we fertilized or inseminated, and we check to see if there's fertilization that occurred. And from days 2 to 4, we like to keep them in the incubator undisturbed, so that way they're provided with the best environment to grow and develop into blastocysts. And then once we get to day 5, 6, and 7, that's when these embryos have hopefully turned into blastocysts. And for a genetic testing cycle, this is when we look at them and decide whether or not they're ready to undergo the testing process. Or sometimes without the genetic testing, we just freeze them. This is also a day we can do transfers as well. And then if you are doing a PGT cycle, around day 15 is when we get those results back. And usually your physician will give you a call. Dr. A will call you with the news of the results. So on day 0, which is retrieval day, once Dr. A collects all those eggs for us, what we do inside the IVF lab is we clean off those eggs, which enables us to determine which ones are mature or immature. And we have about 70 to 80% of the eggs that are collected during the retrieval will end up being mature. And only mature eggs can be fertilized. So for ICSI, we're figuring out which ones are mature, and then we're proceeding with the insemination. And right here is just a quick video of what an ICSI looks like. And as you can see from the picture on the top, the left-hand side is where your holding pipette is. And then you have your egg, and then you have your actual ICSI needle, which carries one single sperm inside of it, and you'll see the sperm dropped off. And this is all done under 100 magnification under a microscope because that egg is so small. So you can see that ICSI needle on the right side, and that little dark dot is what the sperm is. And you'll see the needle go into the egg, and then it'll drop that sperm off. And then immediately after the procedure is finished, you can't even tell anything occurred. And there you have it. So day one is our fertilization check. And there's a variety of different ways an egg, or now we call it a zygote, can fertilize. And what we like to see is what you see on that image on the left-hand side, which we refer to as a 2PN. And this has 2 pronuclei in the center of the egg, which indicates to us that it has fertilized normally. The picture in the middle shows an egg without any pronuclei, which it can suggest 2 things. It suggests that either those pronuclei have already faded or that they never occurred in the first place. Regardless, we keep these ones in culture just to see if they do divide. It means that once we were looking at them, the PNs had already faded. And then you see the egg all the way to the right has a 1 PN, and we keep those as well because that second PN could have faded already. So we give them an opportunity to see if they can develop. Sometimes we'll see eggs with 3 pronuclei. We know that that's genetically abnormal. They can have 5 PNs as well. And again, those are genetically abnormal, so we do not keep those eggs in culture. So then your days 2 through 4 is when you have development occurring. And the images of the embryos at the top kind of shows the still figures of what an embryo is doing as it's developing. And up until day 4, you can see that each cell number is increasing. And then around day 4, all of those cells kind of mold together into one ball. And then towards the end, what you see is a blastocyst. And blastocysts have 2 cell types. They have the inner cell mass, which is the tight ball, and that's what actually creates the baby. And the second set of cells are the trophectoderm cells, and those are what produces and creates the placenta. And if we're doing PGT, the genetic testing, we don't touch the ICM, we're only going for the trophectoderm cells. And a blastocyst has about 200 cells at that stage. And for the genetic testing, we remove anywhere from 6 to 8 cells. So it's insignificant for the blastocyst. And again, they recover and you can never tell anything occurs. This video right here is going to go by pretty quickly, but it's an image captured from our EmbryoScope incubators. And what it does is it takes a picture of the embryo once every 5 minutes and then creates a video so you can see actual development occurring. So you'll see each cell increase in number. There's 4 cells, and then it increases again. And then you'll see all these cells form one tight ball, which is what we call a morula. And then it creates this blastocyst stage. And that ICM is right at 12 o'clock. And that is a pretty beautifully looking blastocyst. So for pre-implantation genetic testing, a blastocyst needs to reach a certain quality. Unfortunately, not all blastocysts will turn out to be looking like the video we just saw. Some will have degenerating cells, some will not have enough cells. So we create and assign grades to each one of these, and then we have a threshold that if something is below the threshold, it means that it won't be able to survive the process of biopsy, or it won't survive the thaw freeze process as well. So unfortunately, just because something is fertilized, it doesn't mean that it's going to reach this great blastocyst quality size that will be usable for the future. But this video right here is going to show the biopsy. And again, you'll see that holding pipette on the left-hand side, and this is all done at 100 magnification as well. And then you'll see that biopsy pipette, and the red dot is the laser, which we use to separate those cells. And it's a pretty quick process. It takes about 30 seconds. So you'll see those cells separate from the blastocyst. And then the embryologist is going to zoom out, so you'll be able to see the cells separated from the blastocyst itself. There you have it. So that's still on 20 magnification. A blastocyst, sometimes you can see with the naked eye. Unlike the egg, you cannot. But once these start to get around 200 cells, you can kind of sometimes see a little dot if you have good eyesight. So then after PGT, or just we can do straight freezing with no testing, which also occurs on those same days of culture, day 5, 6, and 7. Cryopreservation occurs, which we also call vitrification. And when we're freezing, there's multiple steps that we use for identification. And a lot of patients ask these questions these days, because unfortunately we do see a lot of news topics about things not being properly performed in the IVF lab. So here at SCRC, we do have multiple double witnessing steps to make sure that none of that ever occurs. We have our paperwork that states the patient's name and date of birth, and then also a unique identifier, which in this case is the EMR number. And that's on, so that information's on your paperwork. It's on the device itself, which each embryo gets its own device. And then it's also on the cane, which is kind of the item that we use to store the devices in. And you'll see this in the video. And I'll point out in the video as well our monitoring system, because all of these tanks are monitored 24/7. We also, an embryologist checks on them multiple times a day. We want to make sure everything is safe, and so that does require daily maintenance. So the white box is the alarm system, and you'll see a probe that goes into the tank. And if any temperature is changed, that's when we are notified that something is not within our threshold. And this is the cane that each device is in. And typically this will have a label on the outside, on the top of the cane and on the outside of it as well. And then inside this cane, in this case, it's a yellow device. And then you'll see the white label as well. I think it's a little too small, but that label has all 3 different identifiers. For each embryo is labeled exactly that way. And then on transfer day, usually the most exciting day for patients, we thaw embryos in the morning before transfer. And again, we have these double witnessing steps. Before the thaw occurs, everything is made sure that it's matching. During the thaw itself, there's a double witnessing, and then again at time of transfer. And also for transfers, we have a monitor in the room, so every patient is able to see for themselves that the dish that the embryo is stored in has the correct patient name and date of birth as well. And this video will show you kind of what goes on behind in the IVF lab at time of transfer. So you see the embryologist has a second person where they check the label, the paperwork, and the dish themselves. They make sure everything matches up. And then this is usually what the patient will see on the screen of the name and date of birth. And then this center part is where the embryo is. This is what the catheter looks like. As you can see, it's pretty soft at the tip. And the embryo will load, or the embryologist will load the embryo into the catheter, and then she hands it off to the physician. And then Dr. A is going to finish it out with her side of what occurs for the embryo transfer.
Thank you, Robyn. I always think the videos are so beautiful. It's like breathtaking, because we on our side worry so much about which protocol is going to get the best quantity and quality of eggs, and how are we going to keep the patient safe for the retrieval and keep all the systems a go. And then we work so closely with you guys. It's so beautiful. So we need about 3 months prep time for an embryo transfer, because we want to make sure your BMI is ideal, that you're not iron deficient, your vitamin D is healthy. We want to make sure you're up to date with your pap smear mammogram, as well as making sure you've been on prenatal vitamins, and that your system's as healthy as possible in preparation for the embryo transfer. There's a couple different protocols to get the lining to thicken so that the embryo can really implant and have the best opportunity. You can either naturally ovulate or super ovulate with ovulation induction medications, and then plan the transfer depending on whether the embryo is a day 3 or day 5 embryo. You also, the day of the transfer, we give a lot of tips on nutrition, think about acupuncture that day. We talk about whether we want you to rest for a couple days after the embryo goes inside, and we check a pregnancy test 10 to 14 days after the embryo is placed inside. And depending on the quality of the embryo, your age, and certain qualifiers, we can talk about statistics as well. It's important not to overdo it. Sometimes people are used to having a high stress job and really a lot of activities. And so in general, there's no perfect answer. Some doctors really believe just go back to normal even that day and stuff like that. We tend to say try to take it easy, just not overdoing it. If your heart rate goes past 135, you're deviating the blood from the uterus. So it's good to not overexert yourself. And the uterine contractility is a little higher if the system thinks it's in fight or flight. So if you're really amping up and running and doing vigorous exercise, sometimes the system wants to have some contractility in the myometrium or muscle of the uterus. And so it's good to think about it. Also, if you've had a retrieval, an egg retrieval, we want the ovaries to kind of go back to normal size. And that can take about 10 days. So no intercourse or vigorous exercise after the egg retrieval. So your body can heal up properly and well too. Next.
Okay.
All of us here at SCRC put a lot of dedication and compassion into every single patient, and we work closely with you to give individualized care. So feel free to reach out to any of us here. We're all very dedicated, and you can see our amazing embryology team. Next slide. And in terms of, we did get some questions. I can go over some of those questions here. I saw the first one was, I'm planning IVF in 6 months. When do I start prenatals and acupuncture and lifestyle modifications? Generally speaking, sooner is better because it's good for your health, but at least 3 months ahead would be ideal if you're planning 6 months ahead. Sometimes if a patient's older and their egg supply level is a little lower, we may only have the blessing of a month prep for them, and that's okay. We have to work in those circumstances, or in cases of cancer or medical conditions, sometimes we don't have the luxury of time. So we're kind of prompt to jump in and help. The next question is how early to change alcohol, CBD, or weed. Also for men, that does take 72 days to kind of revamp sperm quality. So a few months would be important. In women, there's a 90-day kind of concept for ovarian wave or follicular development. And so generally speaking, we say about a few months for those types of things. The next question was about insurance and costs. It's good to talk to our financial counselor. Once you've had a visit, we can discuss it. Plus, they have an insurance verification team here. So you could ask our team as well about that. The next question is, if my partner had a vasectomy and cannot get it reversed, how do you know the sperm quality? That's a really good question. Generally speaking, we think of the man's body weight, medications, exposure to toxins. We talk about also taking the vitamins as a precaution. And then testicular sperm can get obtained with a urologist who's an expert in fertility. And so we work closely with them. We can still check blood tests on men, such as morning total and free testosterone, thyroid, prolactin, estradiol, FSH. So Sometimes we may not get to see a semen analysis, but we can use certain targets for those levels to see what we can do to adjust or tweak them. Next question is, I have 47XXX. How would this affect getting normal embryos? So in that, we see that occasionally. And so we would talk closely with a genetic counselor. In our facility, we have Caroline and Pam through Tandem Genetics. And we would communicate closely so you can really understand the odds of success and the genetics aspect of it with a genetic counselor, and we would see what we can do to help in that circumstance. Another question is, I've been exposed to aspergillosis. How concerned should I be? So in those cases, we get asked this a lot in LA, in terms of exposure to mold and toxins and things like that. So there are interesting ways to improve your overall health. So I always say we want to feel as healthy as we can possibly be, especially before the embryo transfer, because it's already in the lab frozen usually. And so we have the window of time to get you as healthy and detoxed and everything like that. But we would talk to your doctor about a mechanism for that and see your inflammatory markers like CRP, ESR, and think about things like that. Next question. It's a really good question. Stressful, all like working and stress and the responsibility to have good nutrition, exercise, everything in moderation. So some people are weekend warriors, and I always find that funny because I feel like I am too. Like I work really hard all week, and just sometimes on the weekend I look forward to getting an opportunity to get outside and stuff like that. So I think just don't be too hard on yourself. You can't change the past. You can only look to the future. And so the person was asking about stress and nutrition and exercise, just everything in moderation. Try to at least exercise 3 days a week for 30 minutes. Over nutrition is over 7 days. One of the days you can have like a free day of whatever you like, but the other 6 days you might want to plan ahead and meal prep and things like that if you can. The next question is about a male who has a low-grade varicocele. I think it's a really, really good question. Some of them can impact sperm DNA fragmentation. And so once again, we talk about antioxidants and lifestyle things, but we work closely with the urologists because occasionally they'll look at the FSH and LH levels and they'll talk about different options of medications and things that may improve the success for IVF if that's the plan. Because it is like preparing for I joke, for the Olympics when the Olympics are Friday, which is exciting, but you really want to plan ahead because we don't want to get a set of eggs and get aneuploidy embryos or unhealthy embryos and wish we had worked better to improve the odds with sperm quality. So it is good to have a work closely with a fertility urologist. So the next question is ureaplasma. It's important with ureaplasma to treat both partners at the same time and no intercourse during those 2 weeks. Sometimes with ureaplasma, it can be resistant or persistent. And so sometimes we have to treat it with a different antibiotic for 3 weeks. But I think in general, if we caught it, we are trying to get that to improve before an embryo transfer. For the egg retrieval, most of the time we're using prophylactic antibiotics as a precaution. And so we may not have to be as alarmed about that, but we could talk about it and discuss the risks and benefits of things like that. And I think this is the last question, is the mini IVF, which a lot of people ask us about in our facility, because the egg retrieval and the ICSI and embryo development, it's all one experience for patients. So we don't have like a set mini IVF here. What we do though is really tune in. So if someone is older and their follicle count's not high, and giving so much medication may or may not really change the blessing of the egg quantity. Sometimes we do think about like a mini IVF, which is less medication to push the set of follicles to grow without a huge amount of gonadotropins or injections. But it's very individualized, and it really, we have to evaluate what you've done in the past and try to determine what's going to get the best outcome. So there's not like a cookie cutter sort of protocol. Oh, a few more questions came through. Robyn, did you have any?
Yeah, there's a few. One of the first lab questions is, where was it? Why, rumor on the street is your lab is the best. I like that one. What makes your lab better than others? I think in IVF, a lot of laboratories get scared with change, because with change, there's always an opportunity for something to go wrong. We're really lucky here at SCRC because of the high number of patients we have. We have a lot of patients that donate to research. And with that research, we take our current protocols and we tweak them, and we see if this freeze technique produces better survival. What can we do? So we really value those embryos that are donated to research, and that's what gives us the ability not to just stay comfortable, but to always strive to be better and to improve our protocols. So we never stop. There's always room for growth and development in the IVF lab, and we're really lucky to have a lot of experience in the IVF lab. We have really great leadership. And so every time, if we have any patients that, come through a few times, we always talk with the physician and see if there's something, we can tweak this, we can do this better. We're never resting until we get better outcomes. And I think that's what really makes us, that's the biggest thing that separates us from all the other IVF labs. There's another question about new freezing that came out in 2019. And if you froze your eggs before 2019, does this mean that you're going to have lower success? And if it was froze, it's more in, I mean, it varies from lab to lab as well. So in 2019 for our IVF lab, we had this down routine. So it would be more like 2015 and before. But it comes out right away. You would see your eggs don't survive the thaw. But if they do survive the thaw, the development is equal to if they were fresh. So the good news is you would know right away as soon as they're thawed, and that our number is closer to 2015. 2019, we still have great results. Our numbers are 2019, they're in the mid to high 80s for survival. Now I would say 2023, 24, we're in the high 90s, high mid 90s.
We just had a pregnancy with a 13-year frozen egg, which was
it's
I like
a lot of people,
tears of joy with that.
Right. And we know with embryos, we're high 90s. It's mostly 98, 99% survival rate. It's still possible an embryo doesn't like to be frozen or thawed, but it's very unlikely. So we have great results with embryos.
To survive the thaw, but yeah.
Yes. And Dr. A, someone said, do you evaluate immunology issues prior to IVF or work with reproductive immunology?
So we work with rheumatologists because at Cedars and UCLA, there's a few that are super knowledgeable. They even, they really tuned into fertility treatments and things like that. So I personally work with the rheumatologists at either Cedars, UCLA, or in Santa Monica, depending on the patient's insurance and stuff like that. They do a deep dive into all the different parameters, and then they'll work together with us to give us a strategy. I saw a question about MTHFR. We're asked that at all the podcasts we do. The Maternal Fetal Medicine Society, SMFM, doesn't think even for reproductive endocrinology we should be too concerned about it. I think I tend to tune into family history. So if someone says their mom had a few miscarriages, I always think to myself, okay, let me check this, let me think about it. But at the same token, if you take folate, it should overcome the MTHFR dilemma, but a fasting homocysteine level shows us that if that's healthy at a healthy level, then the MTHFR is not really doing anything. So I wouldn't be too worried, but some philosophies are that it's a big thing and really make it big. I don't like to stress people out if the fasting homocysteine is healthy. Let's see, I'm going to see what other questions. Someone had 5 IUIs, and then would I complete new testing and a waiting period? That's a good question. Well, so for us, the AMH tends to ebb and flow over 6 months sometimes. So I like to see the trend if I'm going to plan IVF, because it's used to decide in part of the picture for the protocol. The new testing for IVF mostly is a checklist of important tests that we use to guide us to prepare you for IVF. So there might be more tests your doctor may need to do if you've had many IUIs in the past too. Go ahead.
Somebody said, do you only offer ICSI, or can we choose natural embryo creation of just sperm and an egg in a dish? Not sure what it might be called. So your 2 options are ICSI or natural INSEM, and we do offer both. We tend to do a lot more ICSI because with natural INSEM, there are hundreds, if not thousands, of things that could go wrong between the communication of the egg and the sperm. So there is a higher chance of a no FERT case. But usually what you do is you talk that over with your physician. You have to have, we have a threshold for sperm parameters, so you have to have good sperm. Age can play a factor as well, but usually that's a question that you would ask Dr. A, and she'll let you know if she thinks you're a good candidate for the INSEM or if she suggests to ICSI all.
Yeah,
and then
I like lose sleep over that decision, because part of me wants to try to do things natural because that's like your instinct. But at the same time, if someone has been trying for a while and hasn't had a pregnancy, nature with the egg and sperm near each other isn't making a fertilization or a pregnancy. It's hard to think that in the dish, why would we think we're automatically going to get a different outcome? So it's kind of a typical thing to think about pushing the sperm into the egg, which is called ICSI. But I think in general, if someone had a family history of any epigenetic things or different things, we would go into detail for each specific scenario. Again, so, but we're happy to think of other questions in the consults too. And I think in general, overall, again, every patient is unique. And so we're just trying to work together and work closely with your partner to talk about lifestyle and things like that. And so I think it's all like with the goal of a healthy baby, a healthy pregnancy. And I really am happy to work closely with Robyn, and thank you for your time today.
yeah.
Next slide, let's see.
I think that's it. There's one more question that says, can you talk a bit about more genetic testing of embryos, i.e. what you're able to test for? In general, we do PGT-A, which what that does is it looks at every embryo should have 2 copies of its chromosomes. And what it does is it makes sure that there are 2 copies. Sometimes there will only be 1 copy. Sometimes there will be 3 copies. The most well-known example of 3 copies is Down syndrome, which is 3 copies of chromosome 21. We also do PGT-M, which looks at specific genes on a chromosome. And we don't typically do that unless there is an indication for it. If one of the parents has a genetic abnormality, then we would look at that. And then the result that we're looking for is euploid, which means that from what the testing found, everything was proper amount of chromosomes, and single genes were correct as well. But you can have an aneuploid result, which means there's an abnormal amount of chromosomes. And then you can have a mosaic result, which is a hot topic in the IVF world these days, which means that some of the cells we sent for testing came back euploid, and some of the cells we sent for testing came back aneuploid. So it's the famous example we use is a soccer ball, how usually it has black entities and white entities. That's kind of the example of what the embryo has. And those, there's a million different possibilities with those, which is why we have a full-time genetics team with us. And if we ever have any mosaic results that come back, you speak with Pam or Caroline, and they walk you through every step of what they recommend, what they don't, and we walk you through whether or not we're able to transfer it. There are a few IVF labs in Los Angeles that transfer mosaics as well, but it's a case by case. We go over every detail once those results do come in. And like I said, Dr. A, she gives you a call once your results come in, and that's your opportunity to ask questions and then speak with our genetics team as well.
And on that same line of question, which was, what is the genetics on the embryo? What are we testing for? If you have a strong family history of early Alzheimer's or breast cancer or Lynch syndrome for colon cancer and things like that, sometimes we have to work with medical genetics to see if either you or your partner carries a specific gene. And that does take a little time, but that's called PGTM. So that's a specific gene. Because some of our patients, they test everything possible that you possibly can. You can only test for those specific targets if you actually carry those genes. If we're looking at like a catchment of a wide variety of things, that's not very specific for an embryo. Because all of us have different genes that may or may not impact our lives. And so when patients say test everything you can possibly do, we're mostly looking at aneuploidy screening for specific chromosomes or a specific single gene that you carry or your partner carries too. Yeah. But thank you.
Somebody else asked, do you want to answer one more? It says, do you have an age?
Sure.
An age limit that you will do IVF with?
Oh yeah. Well, so our ethics committee agreed that for plain eggs to freeze, we'll go to age 44, but in some states where they mandate fertility coverage, I talk to all my friends on the East Coast a lot, and they are very strict about 40 usually for egg freezing. But here we've had pregnancies with eggs from women into their 40s. We've had healthy embryos into our later 40s, but those patients were making embryos, and an embryo, it tends to be more robust and stronger than plain eggs. And their AMH and FSH and ovarian reserve were a little bit of outliers where their body was, their system had a higher ovarian reserve than you would have predicted at age 45 or 46. I think it's hard because we're trying to balance the odds of getting a genetically healthy embryo, and we want to help every couple no matter what age they are. But at the same time, we know that no matter what we do as women, when our ovaries start to age, we don't have a way to sort of reverse that. And so I think it's, as an older parent myself, I think it's really hard because everybody wants an opportunity for their own eggs and sperm, but at the same time, sometimes we have to write out our pros and cons and the risks of the procedure and things like that. So there's no hard and fast rule in our facility. We take it case by case.
Somebody asked a gender selection in IVF and IUI. We do offer a sperm processing technique that separates male and female, but we do know that it's not the most effective way is to do PGT testing, and that'll tell you if what sex the embryo is. Sperm processing only increases your chances by about 5%. So we typically don't offer that off the bat, but we do have some patients that, you know, it's kind of their last hope and they want to do everything we can, and that is an option.
As long as the
someone's
semen analysis looks good.
Yes,
Yeah,
exactly.
so that's good.
And someone said, which embryology techniques increase the probability of either gender? And they listed, I think they meant to say Pixie or Zymot. Neither one of those change gender. They're just, Zymot's a different way to process sperm, and Pixie is another sperm selection for ICSI, but neither one would help with gender selection. Somebody asked, how much does an initial consultation cost?
I stay a little bit out of cost because again, as the medical doctor, I worry more about the mechanics of things, but we have a insurance verification team and a financial counselor that you could work closely with. But I really appreciate your guys' time today, and I'm happy to see anybody, and all my partners can see anybody in consultation to answer any other further questions. And I hope we at least touched on some of the things you guys are thinking about, and we wish you good success and a healthy pregnancy and all the best. Thank you, Robyn, too, for your time today. Take care.
Happy almost World Embryology Day.
Awesome.
Bye, everybody.
Bye. Take care. Bye-bye.